Hi, Peachy, are you there?
Yes, Father President, we're here. We'll be
Uh,
starting. Yes.
I just wonder if I can, because my camera is
Chair?
not on, not
Apo?
sure if I can, uh,
Yes, po.
okay, because I not sure if I can change okay, I have it. Okay. But to switch on the camera, you need to let me do it, right?
Oh, let me let me tell to the IT team.
Yeah, because I cannot.
Apo.
And I need to share the screen later.
Can can we try now, sir?
Yes?
Or you cannot?
No, I cannot.
Oh, okay po.
But I can share my screen, right? You see my screen, right? Just not my camera.
Yes, I can see your screen, but not your
Screen
camera.
is okay,
Can't see
yes.
you.
Oh, maybe something wrong with the camera. Let me double check. Let me finish. Stop sharing. Oh, that's weird. Let me this one.
Is your laptop close the camera or something? Check.
Yeah, because this is the external. Let
Oh,
me
okay.
uh, but everything seems fine. I can't. That's weird. Let me check. Oh, we still have 5 minutes. Okay. Hmm. Everything is plugged on though. Okay, let me restart. Let me restart my computer.
Yes, po. We'll wait.
Hello, Jeffrey.
Yes, Mr. Locke.
Yes. Good evening.
Good evening. Good evening. So good to see you.
Yes.
Hi, everyone. Welcome.
Hello, good to see everyone.
Hey, Kodama.
Hi.
Hi,
Yes.
Kodama.
Hi, Kodama.
Hi. So, last night I returned to Japan. So,
Uh-huh.
Yeah,
yeah.
very tiring for you from Bangkok. Is it from
Yes,
Bangkok?
and Mahidol University. So, but this Tuesday, next Tuesday, I will go to the ISRRT and Vienna. So very busy.
Wow.
Maybe Napapon same. Same. Yeah.
Okay, it works now.
Okay,
Philip.
welcome back.
Philip.
You hear me all right, right?
Yes.
Yes.
Yes. Okay. I need
Philip
to
will be
restart my
joining soon.
computer.
Yeah. Hey, Philip is here. Hi,
Philip.
Philip.
Yes, I'm here. Hi, you hear me?
Yeah.
Yes, I hear
Yes,
you.
okay.
Yeah.
Okay.
What time now in France? Philip, what time now?
Sorry?
What time
What
now?
time? What time? It's noon. It's noon.
Yes, okay.
This one, two. Yeah.
A very warm welcome to each and every one of you from Asia and to all our audience worldwide. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technology Societies, and hosting the 59th CPD Asia is the International Society of Radiographers and Radiological Technologists, ISRRT. I'm Peachy Luna, your CPD Asia program host. We are live streaming on YouTube. You can search PARI, VART channels, or you can join us live or watch a replay. This is a special program of the CPD Asia. Each year, we are grateful to the ISRRT Board of Management for giving us their invaluable time to discuss updates, reports, and significant developments about the state of medical imaging and radiation therapy, education, and practice. We welcome the ISRT President, Dr. Napapongpong Napang, Vice President for Asia and Australasia, Madam Chek Vitan, Mr. Philip Gerson, our ISRT Treasurer, and Yo Lee Win, Speaker from Singapore. This CPD Asia is highly supported and graced by member societies, presidents, all the officers, and their representatives. Let us greet and welcome, attending for President Fernando Koch of Macau, Radiological Technologies Association, is Vice President Chin Shun Yu and Chairman Jerry Lei.
Hello everyone.
We-
Nice to meet you.
All right, and we have President of Vietnam Association of Radiological Technologists, President Thai Van Loc.
Thank you. Good evening. Today very special. Congratulations, ISRRT. Congratulations. Thank you so much, ISRRT.
Yes, good evening. Attending also is the President of Hong Kong Radiographers Association, HKRA, Mr. Nang Tat Ning.
Hi, good evening, everyone.
All right, of course, we have here Singapore Society of Radiographers President Denise Chu.
Good evening, everyone. Good to see you all.
And we also have attending for President Katsuhiko Ueda of Japan Association of Radiologic Technologies, JRT, and also our ISRRT officer, dear Sir Naoki Kodama from Japan.
Good evening, everyone. Today's workshop hosted by ISRRT. So, thank you so much.
Yes, thank you, dear sir. Attending for the Perhimpunan Radiografer Indonesia, PARI, is Mr. Putu Adi Susanta. And we have our past president of the ISRT, India Society of Radiological Technologies, President Selva Kumar.
Namaste. Warm greetings to all.
And we have received greetings from President of Malaysian Society of Radiographers, Mr. Sawal Marsaid, President Vitarana Gamij Vimalasen of Society of Radiological Technologies, Sri Lanka, Vincent Kuwei Fang of Taiwan Society of Radiologic Technologists, Mr. President Muhammad Abdul Ghani of the Palestinian Association of Medical Radiation Technologists, President Sophie Lee of the Association of Cambodian Radiological Technologists, and President of Philippine Association of Radiologic Technologists, Mr. Ruben Lorenzo. All right, so all of them will be joining us again later during the Q&A session. But for now, may I request everyone to please open your camera and let's have a short photo opportunity. All right, thank you. Okay, wait. All right, so let me now introduce.
Hello.
Yes, let me now introduce our speaker as we begin, our moderator for this program as we begin the program. All right, so our moderator for today's session is Madam Chekwi, the Vice President of the ISRT for Asia and Australasia. Chekwi is currently working as the Senior Principal Radiation Therapist at the National University Cancer Institute, Singapore, and has been appointed with the Singapore Institute of Technology as Senior Lecturer for Radiotherapy Program. Chekwi is deeply committed to professional development and is very active in both local and international radiography commitments. She has previously served as the President of Singapore Society of Radiographers and the Regional Director for the Asia and Australasian region of the ISRRT. Recently, she was elected Vice President of the ISRT for the AA region. Ladies and gentlemen, let's welcome our session moderator, Madam Chekwi Tan.
Thank you, Pichi, for the kind introduction. A very good evening to everyone and welcome to the Asia CPD. On behalf of the ISRT, it is my great pleasure to welcome all of you to the 59th Asia CPD session, and thank you very much for taking the time to join us on a Friday evening. I would like to take this opportunity to thank the Asia CPD Committee for inviting ISRT to present and share this platform. So as we know, the Asia CPD initiative has come a long way since it was first introduced during the COVID-19 pandemic, and it has continued to serve as an important platform for professional learning and regional collaboration in the Asia region. Well, earlier on, before the start of the session, many of you would have seen the slide sharing on the ISRT World Congress that's going to take place this year in Dubai. I hope that all of you are excited as I am and looking forward to this wonderful conference. I would like to take this opportunity to invite all of you to the ISRT World Congress 2026, which will be held from 27 to 29 of October in Dubai. This is a particularly exciting milestone for us as it is the first time that the ISRT World Congress will be hosted in the United Arab Emirates. So this conference promises to be a vibrant global meeting for all radiography professionals, bring together colleagues from around the world to learn from one another, build connections, and explore innovations in shaping the future of medical imaging and radiotherapy. And we are really encouraged by the strong interest shown so far, as we have received over 400 abstract submissions, and we are looking forward to welcoming all of you to the ISRT World Congress. So for today, Asia CPD, we have lined up 3 wonderful speakers who will share their valuable insights across from a wide range of topics, from radiation protection, radiotherapy, and updates on the impactful work the ISRT has been doing for the radiography profession in Africa. We will have the Q&A session at the end, but please feel free to post your questions in the chat box at any time during the session. And now it gave me great pleasure to introduce our first speaker, Dr. Napapang Pongnapang, President of ISRT, who is no stranger to many of us here. So today he'll be sharing with us on human design engineering from the radiation protection vantage point, a radiographer's perspective. So let us welcome Dr. Napapong.
All right. Good evening, everyone across Asia, and this is my great pleasure and honor to meet you guys here in this Asia CPD. Always admire this activity that we have done together across this region as the platform to promote the training and also professional development. So the topic that I will talk about today is on human design engineering from the radiation protection vantage point from the radiographer perspective. Actually, I presented this topic at one of the biggest radiation protection conference in the world, because every 10 years, the IAEA, the International Atomic Energy Agency, would host this conference, and the last one was held at the IAEA headquarters in Vienna last December. So I was one of the speakers in this big conference that will set the scene for radiation protection for the next decades. So basically, I have no disclosure. So the content of my talk will be about to define human design engineering from the radiation protection vantage point, and how failure in human design can create risks. Also, how to position radiographers as the essential component of the radiation protection system, the experience, and also the way forward. So first, I would like to set the scene as defining the challenges, because the digital revolution brings complex technology. Like in 2026, this year, we have artificial intelligence, we have advanced CT, interventional radiology, we have also dose management systems, and so on. Radiation protection is often seen as technological fix because technology is around us. But the greatest risk factor remain the human technology interface. So who take care of the technology? This is the technologist or radiographer. So true optimization is achieved not just by installing new technology like what I said before, but by engineering workflows and interfaces that support and empower the human operator. That means the radiographers, us, to make safe, correct decisions in every single time that we expose the radiation to our patients. So the core problem here that I would like to identify is human factors in radiation protection. First, we talk about automation paradox. Now AI comes along, before we have AI, we have AEC, automatic exposure control, dose management, and also in CT, we have like ATCM, automatic dose tube current modulation. Everything is pretty much automated. The operator becomes less engaged and less skilled as manual override. That increases the risk of error when automation fails or misinterpret the clinical scenario. That's why we always talk about human and also technology interface. Who bridge between the technology and the patient? That's the radiographer. So the interface design and cognitive loads, complex dose display. Now we talk about since during the past 10 years, the requirement from the FDA and also other organizations define the necessity to display those metrics in all the imaging modalities, and these can be complex display, counterintuitive manuals, and poorly designed protocol that increase cognitive load on the radiographer, because we have to take care of a lot of things. Once the patient come in, we have patient interaction, we explain the procedures, and when it comes to the technical parameter setting, we have to deal with a lot of things also, and that includes the radiation dose interpretation. For example, non-standardized terminology between vendors that leads to confusion, and protocol selection errors directly impact the patient dose. What next? Workflow fragility. Show how clinical workflow are easily broken by minor errors like incorrect patient data entry. Radiographers, we are human. We interface between technology and the patient. So we have to do the patient data entry correctly, sometimes bypassing safety checks due to time pressure. For example, we have like 20 patients waiting for us. How can we be sure that radiographer is competent? Radiographers understand all the process, and radiographer is the last line of defense, but also the most vulnerable point if the system is not designed to support us. So the key is we need to position radiographer as the essential component of the radiation protection system. How? We all talk about justification, optimization, and those limitations, right? With the patient's examination, we talk about the first two. Justification, of course, during the past 10 years, from the Bond Call for Action, the last radiation protection conference that held before this one, we have a lot of activity, and ISRRT has been involved with this justification. We developed the justification flow chart, and we show that we do have role because we see the patient's examination requests first. And then after the exam is justified, that it goes to optimization. Optimization happens at the bedside, at the gantry, require real-time critical thinking like protocol selection, patient positioning, use or not use the shielding. So ISRT mandates we ensure that radiographer has the competency and the authority to adjust parameters within the established limit for optimal dose. So we are important in this process because at the end, justification happen at the bedside or the gantry. That's the way it works. Next one is data fidelity and dose management system. A lot of hospital now we use this dose management system, the DMS. DMS can be useful if the input data entered by the radiographer is accurate. So a good human design approach ensure data entry is fast, minimize typing error, and is integrated within the DRIS and HIS system. Training and simulation, right? The next one, advocate for incorporating human factor engineering. This is a terminology that we talk about, and I believe that we need to implement this one into our education and training for the next generation radiographer. Human factor engineering, HFE principle. Focus on early recognition and safety culture. Encourage reporting without the blame because we work in this kind of environment. But look at the current situation. This publication done by Jonathan McNulty and Andrew England group on the Radiography Journal talk about international perspective on radiography practice education. I will talk about ISRRT work later. So this publication has a big impact because it was the most recent data that we have at the moment. So from the global perspective, program structure, majority of us, 84% of the entry route is bachelor degree now, with specialization, either diagnostic being most common. And we have clinical reality like clinical placement. That's the challenge everywhere, not only in the developed world, also in the less resource places too. Because how can we make sure that our students are competent after the graduate? And then we have technology shift, increased adaptation of simulation because it's very difficult to get the clinical placement these days, and also the workforce impact. The global heterogeneity in qualification level and duration of the education create major barrier to international mobility and mutual recognition by radiographer. Not talking about global, even in Asia, we know that our education system are quite different, right? To have the cross-border practice, like if I'm a radiographer from Thailand, I want to go to work in Singapore or Hong Kong, there's going to be some barrier because our training is different. So that's quite a challenge. And if you look at another scenario just recently published from the IEA work from Shane Foley and also Jania Vasavela from the IAEA, they talk about large differences in education and training for radiographers in Europe and Central Asia. If you talk about Europe, you might have thought that they have kind of harmonious training, but in fact, there are vast variety of the program training. So they found that program duration range from 1 month. That's kind of crazy, right? To 4 years across 30 countries. And clinical training, practical hours very widely range from 250 hours to 2,000 hours. And while 58% of the program are higher education, 29% are close to 30% are short course. That is less than 2 years. That primary in non-EU nation. And what about radiation protection? In Europe, they have the Euromed program that they do education and training in radiation protection, the project survey. I just kind of summarize, training the radiographer is one thing, and component of radiation protection in radiographer training is another thing. But when we look at these two components together, I think this project can somehow outline the problem that we might have. So top three problem identified by more than 60% of the responder: lack of practical, non-mandatory nature of CPD, insufficient inclusion of radiation protection topic. And also they have the data gaps highlighted, like they may not have hands-on education and training in radiation protection, and they also have discrepancy among different kind of subspecialty like diagnostic and radiation therapy. So what else? We have current challenge in radiology, shortage. If you look at this data from the US, ASRT, the American Society of Radiologic Technologists, they conducted a survey every year, and this one was the latest one in 2025. You can see CT shortage. CT shortage increased from 17% to 19% shortage. That's the US. MRI is not better. MRI, the shortage increased from 16% to 17%. Even developed places like the US, they have shortage of radiographer. So if you look at the global workforce challenge, WHO, the World Health Organization, projected that the shortfall of the global shortage of health workers would be 11 million workers by 2030. That's quite alarming. So the key challenges from the WHO: availability, sufficient supply, and appropriate skill mix of health workers to match the population needs. Asia, we may be different. Even across Asia, we are quite different also. Also, accessibility, acceptability, and also last but not least, quality and performance. We need to ensure that health workers have the necessity, competencies, skills, and knowledge, and adequate working environment to provide high quality care. This is the work that I have done together with the IAEA and Monash University in Australia. We team up to run the project for a couple of years already. We call human resource shortage and optimization. We address human resource shortage in these Pacific Island nation. There are more than 10 countries in the island and in the Pacific Ocean. The main issue is that they are quite different, and the majority of them live kind of scattered across the ocean. And the collaboration focused on capacity building and technical cooperation to train radiographers and technologists in these IAEA member states to identify the premier centers to host the training the fellows like Monash University, and now they transform some of the trainees to Thailand and other countries, and like Japan that we just recently host the workshop. And the IEA provide expert support for this activity. What we have done, we have conducted numbers of levels of the workshop to identify this gap. So the level one that we have conducted, we call the toolbox basis. We focus on like practical, pragmatic skill for immediate daily use, because a lot of countries that don't have radiography training program, a lot of radiographers are from high school graduate and on-site training. Some of the country are more advanced, like Fiji, they have the school, Papua New Guinea, they have the school, but most of the countries there, they don't have the radiography school. So the content we look at include like proper positioning, QA and QC tests, radiation protection, and basic image interpretation. And method, we use like lots of lab at Monash University. And then at level 2, we develop a course called Advanced Leadership, because why? In these such places, a lot of places that don't have radiologists, so everything will be under radiographer's responsibility, from doing the exam, image interpretation, we call preliminary image evaluation per se, because we don't really interpret, we do PIE, preliminary image interpretation. And I think this one will come along because like radiographer's report can be very important, especially in the emergency cases. So the content we talk about, we develop like leadership skill, cross-functional influence, and the quality management system. So we also include the advanced modality like CT, ultrasound, MRI, and also mammography. We talk about sustainability and innovation. The course is unique because for radiographers, by radiographers, so curriculum based on local needs assessment taught by peers to ensure relevance. So radiographers teach radiographers because we know what our colleague need. And we use modern technology like integration of medical informatics, teleradiology, and AI application. And we encourage them to have regional autonomy, right? They create the regional clinical audit system and establishment the regional professional society. We have the Australian Society, ISRRT, to come to help them to kind of discuss with them how to form the professional society. And later on, they will join the ISRRT family. There are more than 10 countries in that region. And of course, there will be in our region, AA region, Asia and Australasia region. So the impact, we empower local staff to manage regional radiation system independently. And the latest workshop that we have conducted last year in July, the new cycle project will start this year. We developed the workshop on innovative technologies in medical imaging. Also, this workshop will focus on quality management, quality and radiation safety, and we add on the item that will be very important to them because they are living in the remote places like medical informatics, teleradiology, and also application of AI. So on top of that, we introduced the PIE, the preliminary clinical image evaluation. Basically, it's the radiographer's reporting system and also optimization. There's a pathway forward, the path forward collaboration design. The ISRRT, we signed the MOU, but terminology used by United Nations, they call practical arrangement. We did sign 2 years ago between collaboration between IAEA and ISRRT. So we have three main collaboration scheme, including mandate usability testing, standardized interface, strengthening education and training for radiographers and radiation therapists globally. So in conclusion, why I talk about radiation protection is important, but the point is we need to have the design of the curriculum, design of the training system, and also the proper competency-based, outcome-based training for the radiographers, because at the end, as I said, radiation protection in terms of optimization happens on the bedside. That is like the X-ray table and also the gantry of CT. So in summary, We must shift the focus on fixing the machine to engineering the environment around the human operator, because we know that even in such remote places, we do have technology. One country that I'm supposed to go to visit is in Samoa. They have, I think they have a 196 slices CT scanner without proper trained technologists, because I met the technologist that she just graduated from high school. That's very alarming. With such technology, we need someone capable to understand how to operate the machine, how to do proper technical settings, and also radiation protection for the patient. So the final thought, for the next decade of radiation protection, let us ensure that our most advanced technology is supported by our most valued resource, the well-trained, well-supported imaging profession, that is the radiographer. This was the message that I sent to United Nations on behalf of the radiographers globally, 500,000 of us. We sent the message to the world that next decades, the next 10 years, we can not just focus on buying the new equipment, fixing the machine. We need to take a look at how we train the users of those machines to optimize the benefit of the radiological equipment that would, at the end, that's going to benefit our patient. So thank you very much for your kind attention. So I will open up for the Q&A later. Thank you.
Thank you. Thank you, Napapong, for your sharing on this important topic, which highlight some of the challenges that we have in radiography education, which in terms affect the radiation protection for our patients and even for the staff. So as we all know, radiation protection remains the cornerstone of our profession, and your presentation actually rightly highlighted that safety and human design or human-centered design are essential in protecting both our patients and the healthcare professionals. Well, so our second speaker today is Mr. Philippe Jasson. Well, many of you here are also familiar with Philippe, as he's the treasurer of ISRRT, and Philippe has done remarkable work across Africa, leading and delivering radiography workshops that has made an impact on professional development and clinical practice. So today, Philippe will be sharing with us on ISRRT workshop in Africa, past, present, and future. Let us welcome Philippe.
Good morning. My name is Philippe Gerson. I'm a ISRRT treasurer since 8 years, and I'll speak about my work in Africa since a long time. And first, the history of our workshop in Africa. It's about 30 years in Africa, and I want to thank two women, Dominique Zerug, my friend from France, and Marion Frank for the help. Marion Frank was the first lady who started set up a workshop in Africa. The French colonization in Africa existed mainly in the western part and the center of this continent. About 18 countries speak French. The English-speaking colonization took place more in the eastern part, in the south, and the process of decolonization started the First World War, and now all the states are free and independent. Nevertheless, there still remain fingerprints of the French state by means of the language, the civil service, and also in the domain of healthcare. The story started in 1995 in Tanzania. Minor Frank, on behalf of ISRC, decided to, with hydrogen fins, to set up the first workshop for African country in Tanzania, in Arusha. They wanted to gather together radiographers from French and English part. They nominated me as official translator. Even my English was horrible. They had good contact with the English part of Africa, Tanzania, Kenya, Uganda, Zambia, South Africa, but nothing from the French part, so they sent letters to all the government, Minister of Health in the French part. The purpose was to educate radiographers from the bush or those who have lacks of education. And at the time we sent letter, we have even no fax. It was a bit difficult of communication than now. They got three reprises, one from Benin, a radiographer working in the bush in a small hospital, one from Chad, a radiographer who was also a leader of the trade union in the health sector, and a radiologist from Mali who got from this letter as a trade union radiographer a good opportunity to travel to the first time to East Africa. The radiology department with an injured patient who had to go through the hospital on this whole stretcher with a big fracture. The distance between emergency department and radiology was outside with no corridor directly on the ground with potholes and stones. The conclusion was that to manage a radiographer workshop with English and French language was not a good idea. That's why we decided to organize, henceforth only one for the French part. The French and African radiology were aware about our action, so they gave us a proposal to host our workshop inside their Congress in Yaoundé in Cameroon in 1997. Thus it was the first Congress in Cameroon in 1997. Then we had a workshop in 1999 in Burkina Faso, in the west part of Africa. Thanks to the Minister of Health of the Burkina Faso and the French Embassy, we organized several workshops in this part of Africa. In 2000, we organized another workshop in the west of Africa, in Ivory Coast, with the help of the CRMRT, the Canadian Association, and the subject was ultrasound. And it was something like politics, because in the French part, most of the radiographers, they don't perform ultrasound, only in the English part. So we tried to do that, and we had a conflict with radiologists, but now we have several radiographers who perform ultrasound, especially in the bush, where it's easy to have a machine, but not easy to have education. In Gabon, in 2002, another workshop in the Central Africa, and in Gabon, the ladies organize the workshop. In 2006, Benin, we got a huge financial support from the government because the president of the Benin Radiographer Association worked at the radiation protection headquarters. It was a big event with around 200 radiographers, and this is a photo picture with the Minister of Health, who support us a lot, and we also have the official TV who was attend this workshop. In Togo, in 2010, we decided to organize our workshop with the help of a Catholic church because it's cheaper, it's very safe, and very clean. In 2012, we've been in Cameroon, in Central Africa. It was easy to organize there because I've got some family in Cameroon, so easy to find the place to organize a workshop. And you can see we have more and more people, around 160 radiographers coming from 10 to 14 countries. Another one in Abidjan, in Côte d'Ivoire, Ivory Coast, in the west of Africa, and as you see, it took place in a Catholic seminar place with around 160 radiographers from 10 countries. The subject was mother and child, which is very important in Africa because you have a lot of pathology for the kids and for the mother. So as in Togo, we decided to organize in a Catholic place, which was better, safer, and cheaper. In 2016, we moved to the Central Africa and Democratic Republic of Congo, which is a place where it was very difficult to get our visa to attend this conference. And thanks to the president, Keith Benza, which is here on the photo, we organized this workshop with a lot of difficulties big before, but when we organized the workshop, it was perfect with a lot of people because Democratic Republic of Congo is a very huge country with a lot of radiographers there. Then we move again to Dakar in Senegal, so in the west of Africa, and we we have been honored by the society and all our colleagues from all the French-speaking countries in Africa. And as you see, they give us some local costume. And because it was the last workshop with my colleague Dominique Zeroux, who was very involved in all of these workshops in Africa. Just to tell you that it's not only in French-speaking countries we have this sort of workshop. We also, ISRT organize workshop in the English part in Rwanda, Tanzania, Nigeria, South Africa. I can't give you any photo there because I wasn't there except the one in Rwanda, because Rwanda was a French-speaking country in the past, and so we had also educator workshop, for example, in Nigeria, and it was one of the subject of our workshop from the 20 years ago. So Rwanda, I attended this workshop, and it was about radiation protection, 3 days workshops, with our colleague from Boniface Yao from Cote d'Ivoire, who was a speaker. I was a speaker as well, because I was graduate in radiation protection. And Rwanda is a very safe country and very easy to organize a workshop. It's one of my favorite country in Africa because it's very safe. You get your visa at the airport. There's no corruption, and we have a lot of securities, and very easy to organize in Rwanda. And we plan to organize more in the future. In Mali, in Bamako, in 2024, we have to face after the COVID, because we have to cancel several times the workshop in Africa due to COVID. But the problem we had is that I can't attend this workshop because there was a military push there with the military force who took the power, and we with conflict with the French government, and it was impossible for me to get a visa to go, and no direct flight to go to Bamako. But nevertheless, we decide to organize this workshop, and that's why one of my objectives in the past, that I helped them to organize a workshop in Africa, but now I'm getting old, and the topic is that they can organize by themselves, and that they did. They organize a very good workshop about mammography in this part of the world. Even it was difficult for some radiographers, even from Africa, to attend. But I was very satisfied because it was on my objective that they could organize by themselves. And now I just here I'm a consultant and not the organizer. Just mention a workshop we had last year in Ghana in 2025 with our Director of Education, Elizabeth Balogun, who organized this workshop close to her country, because she's from Nigeria. And in Ghana, they had a very, very successful workshop, very well organized. I wasn't attend, but it was a very good place, and we always the objective that Mayor Frank did when we created the workshop, it was to help poor countries to organize a workshop in Africa. It's one of the objectives of ISRT. So in Ghana, you can see Elizabeth on the left and Elizabeth on the right as well. And it's very important that we can organize this workshop in the future, because sometimes in some country, this is the only moment that people can gather from different countries. And also it's important that we can have this sort of communication, not only online. Online is good, but sometimes in Africa, you must be on site, because when you go to Africa, you can understand that the people, they want to shake hands, they want to give hugs. It's typical in Africa. So they like to be online, but they also like to be all together and a very friendship people. Just some slides about Madagascar. It was one of my objectives to organize a workshop in Madagascar. And I decided to organize in 2023 the first one. Madagascar is a very huge country, but very poor. They have less of education, lack of education, of course, but lack of equipment. There's only around 10 CT scans for all the countries and around 4 MRI for all the countries. So only 2 in the capital. For example, for the radiotherapy, they have only 1 cobalt at the hospital, who was given by India. And they also have 1 accelerator in a private sector. So they need a lot of education. That's why I decided to organize this workshop. The first was in 2023, and the subject was pediatric. And as you can see on the left, I came there with a lot of equipment. Well, I had around 100 kilo of luggage, and I give them some lead apron. See the guy on the left, he come from the bush, the north part of Madagascar. He worked as a radiographer with no lead apron and no lead, nothing, no protection. So he was very happy to get this lead apron for the first time in his life. And on the center, you can see me with the students, because when I go there, I always give some lectures for the students, third years there, and they're happy to have a teacher from France, because I was teacher in the past in some radiographer school in France. So it's easy for me because Madagascar, they speak French. In 2024, we organized a second workshop with the support of some companies like Neusoft, gave us the opportunity to have the subject as a CT scan and digital imaging. So we had some practical workshop, and Neusoft give them the opportunity to use CT scan with an educator from Cameroon. And it was very interesting. And for them, some people, they come from all the countries. It was the first time they see a CT scan. So very interesting for them. The third one was scheduled in 2025 in October, and was well ready. It was about imaging for women. And I found a sponsor for the bags, you see, with the date on, and the date was in October 2025. But just 2 weeks before, in Madagascar, there was a military putsch, and the government changed and the military took the power. So it was impossible to fly from France. Security was not guaranteed. And that's why we have to postpone this workshop. And this workshop will take place next May in 2026. Also, I'm in touch in the north of Africa. We call it Maghreb, with Algeria, Tunisia, Morocco, and we organize several workshops, and I attend several times Congress. I was in Tunisia in 2025, a radiation protection workshop, and our colleague from Morocco was there, and we invite Algeria, but at the same time they have their own Congress, so they can't come. But it was very interesting, and we plan to have another one in March about CT scan and MRI in cardiovascular imaging with our colleague from Morocco, Algeria, and Tunisia. And the French Association, AFPPE, provide lecturers, as the French Association is a partner of all of these workshops in Africa, because they provide sometimes a lecture, and they provide some money, cover some fees like airfares. We plan to have our big workshop in 2026, we call CAFIMRA. It's a workshop for all the French-speaking countries, but we also invite some English-speaking countries. Even the language is in French. It will be in Congo, Brazzaville, because we have two Congos, the Democratic Republic of Congo and just faced the Congo, Brazzaville, where we plan to organize a workshop. But we have they have a presidential election in a few weeks, so we have to wait the result of the presidential election and then start to organize the workshop, because as you've seen that in our workshop you always have to be aware about the political situation who sometimes change. We also plan to have in Rwanda a mammography workshop, maybe with the help of Siemens, because they have a lot of equipment there, and we have a meeting with Siemens to plan to organize this workshop. We hope this year or maybe the next year. Another one with Neusoft in Yamoussoukro in Ivory Coast in September, maybe, about CT scan and MRI. We plan to organize a small workshop with 50 countries. In the future, we don't want to stop this workshop. It's very important in Africa, everywhere in the world as well. But we have more and more support from companies like Gerbe, United Imaging, Neusoft, the French Association, Siemens, and also Stefanix. Stefanix is a French company who has them since more than 25 years, because to help them in our workshop in Africa. And it's important to have not only the fund from ISRRT, but extra fund, that we can have a very good condition, especially when we organize in Madagascar, who have they have not a lot of money, and they have difficulties to pay and to attend the workshop. So we help them. I just want to speak about Asia, because we organized a workshop, my first workshop inside the Congress in 1999. So you can see some picture of Vietnam in 1999. You see on the left, the guy is a radiographer who comes in our X-ray room with his motorbike and park his motorbike in here. And you also have at the middle the dark room, and the dries all the clothes in the dark room. But Vietnam was like this in 1999, and you see the first CT scan here in a military hospital. But now Vietnam is totally different. They have artificial intelligence. They have all the vascular imaging. But you can see with my colleague, they give education with me in one university, and they thank them by putting this dimension, and they put this tree, and the tree grows, and now they have their name at the bottom of the tree, so of the tree. So it's very interesting, and they thank us for the education we give in Vietnam. Thank you for your attention, and I hope to see you this year in October in Dubai in our World Congress. Thank you.
Thank you, Philip, for your insightful sharing, and thank you so much for your hard work in Africa. You are well loved by all the African colleagues in Africa for your outreach and education. All right, so now we have come to our last speakers for today. So our last speaker for today is Ms. Yo Li Wen. Li Wen is a senior radiation therapist currently working at the National University Cancer Institute, Singapore. And Li Wen will be presenting on functional guided radiation planning in patients with glioma. So let us welcome Li Wen.
Hi everyone, thank you for joining the 59 CPD Asia program. I'm Li Wen, a radiation therapist from the National University Cancer Institute of Singapore, and today I'll be sharing on functional guided radiation planning in patients with glioma, with a particular focus on how functional imaging can be used to preserve cognitive function during radiotherapy. By the end of this presentation, I hope we'll understand why cognitive preservation matters in glioma care, Be familiar with key functional imaging modalities, appreciate the concept of functional avoidance planning, and recognize the current evidence and limitations. Gliomas are the largest group of primary intracranial tumors, accounting for 1/3 of all primary tumors. Low-grade glioma are slow-growing, while high-grade gliomas have poor prognosis and higher malignancy. Approximately 80% of malignant primary brain tumors are gliomas, treated with surgery, radiotherapy, and chemotherapy. As patients live longer, the long-term effects of treatment become increasingly important. Neurocognitive dysfunction occurs in up to 50 to 90% of glioma patients. Radiation therapy contributes to neurotoxicity, affecting memory and executive function, which significantly impacts the quality of life of patients. Therefore, preserving cognition is now a core survivorship goal. Radiation therapy is a cornerstone of glioma management, but it presents a classic double-edged sword scenario. While radiation therapy destroys tumor cells and controls disease, it can inadvertently damage healthy brain tissue, leading to radiation-induced cognitive decline. Modern neuro-oncology is shifting from simply treating the tumor to treating the patient's future quality of life by using functional imaging to map and avoid critical cognitive hubs. Conventional planning relies on anatomical imaging, usually CT co-registered with MRI. Functional regions are not explicitly identified, increasing the risk of unnecessary dose to cognitively important areas. Traditionally, we prioritize proximal structures such as the brainstem and optic structures. In cognitive-sparing radiation therapy, this expands to include structures such as the hippocampus, which is in charge of memory formation, corpus callosum, which facilitates interhemispheric communication, enabling the coordinations of sensory motor and cognitive information, the prefrontal cortex, which manages complex cognitive behaviors, personality expression, and the cerebellum, which coordinates and maintains balance and posture, and also facilitates motor learning. So you may ask, what is functional neuroimaging? Functional neuroimaging maps brain activities and networks rather than anatomy alone. It allows us to identify eloquent and cognitive regions on a patient-specific basis, which is critical in glioma patients where functional reorganization may occur. Gliomas can cause the brain to reorganize, and the speech center, for example, might shift as a result. Key functional imaging modalities include task-based and resting state functional MRI, which identifies and maps functional structures involved in neurocognitive tasks. Diffusion tensor imaging and tractography visualize and map white matter fiber pathways. These are designated as critical volumes to be bypassed during treatment planning to prevent cognitive complication. Advanced MRI technology provides the high-resolution structural framework necessary to integrate functional and fiber data into a comprehensive 3D map of the patient's eloquent brain. Task-based functional MRI imaging maps specific eloquent functions such as language and motor activity through active patient participation, while resting state functional MRI imaging identifies intrinsic cognitive networks based on spontaneous brain activity. Resting state imaging is particularly valuable in glioma patients who are unable to reliably perform tasks due to neurological deficits, fatigue, or cognitive impairment, making it a robust and clinically practical alternative for functional mapping. The goal of functional avoidance radiotherapy is to explicitly incorporate functionally critical brain structures and white matter fiber tracts into radiotherapy treatment planning process with the aim of reducing radiation dose to regions responsible for cognition, language, and motor function while preserving adequate target coverage. By integrating functional imaging into inverse planning, these vulnerable areas can be prioritized as functional organ at risk without compromising tumor control. This approach represents a paradigm shift from purely anatomical avoidance to a functional guided strategy, aligning radiotherapy planning with personalized survivorship-focused care that seeks to balance oncological effectiveness with long-term neurocognitive preservation. In clinical practice, functionally important brain regions and white matter pathways identified on functional imagings are delineated and incorporated into treatment planning system as functional avoidance structures. These structures are assigned an appropriate planning priorities during inverse optimization, allowing the optimizer to actively minimize dose to cognitive regions while still achieving prescribed target coverage and conventional organ at risk constraints. As a result, radiation dose to vulnerable cognitive structures can be meaningfully reduced without compromising tumor coverage or overall plan quality, demonstrating the feasibility of integrating functional information into routine radiation therapy planning process. The workflow begins with the acquisition of functional imaging, such as task-based or resting state functional MRI and diffusion tensor imaging, to identify patient-specific functional regions and white matter pathways. These datasets are then carefully registered to planning CT and anatomical MRI, with attention to minimizing registration uncertainty. Functionally critical regions are subsequently contoured and defined as functional organs at risk. During treatment planning, inverse optimization is performed to prioritize sparing of these regions and maintaining target coverage and conventional organ at risk constraints. The final plan is reviewed within a multidisciplinary team, including radiation oncologists, radiation therapists, and medical physicists to ensure clinical feasibility, oncological safety, and functional preservation prior to treatment delivery. Next, I would like to highlight a study by Buron et al. 2023, which investigated the integration of functional MRI and diffusion tensor imaging into radiation treatment planning for patients with glioma, with the aim of improving protection of critical functional brain regions. This study included 8 glioma patients and evaluated how incorporating functional cortical maps and white matter fiber tracts influence radiotherapy dose distribution. The primary objective was to minimize radiation exposure to neurologically important regions while maintaining effective tumor coverage and meeting standard planning constraints. The study demonstrated substantial dosimetric benefits with functional image-guided planning. Mean and maximum doses to functionally active cortical areas were reduced by 25.36% and 18.57% respectively. Similarly, white matter fiber tracts experienced meaningful dose reductions with a 15.59% decrease in mean dose and a 20.84% decrease in maximum dose. Importantly, these reductions were achieved without compromising planning target volume coverage. The authors concluded that integrating functional MRI and diffusion tensor imaging into radiation therapy planning is both feasible and effective. This approach has the potential to reduce neurocognitive complications and improve long-term quality of life for glioma patients, reinforcing the clinical value of functional guided radiation therapy planning. Another important study by ISRRT et al. 2019 examined the feasibility of incorporating resting state functional MRI imaging data into radiation therapy treatment planning for patients with primary brain tumors. Unlike task-based imaging, resting state functional MRI allows for the identification of intrinsic brain networks without requiring active patient participation, making it particularly suitable for neuro-oncology patients. In this study, resting state functional MRI imaging was used to delineate the default mode network, a key network associated with memory and higher order cognitive function. This network was then incorporated into radiation therapy plans as a functional avoidance structure with the aim of reducing radiation dose to cognitively significant regions and lowering the risk of treatment-related memory decline. The results showed that default mode network avoidance plans achieve meaningful dosimetric improvements with a 20% reduction in mean dose and a 12% reduction in maximum dose to the default mode network. Importantly, these reductions were achieved without compromising tumor coverage or increasing radiation dose to conventional organ at risk. Furthermore, normal tissue complication probability modeling estimated an approximate 20% reduction in the likelihood of memory loss when the default mode network was protected. Overall, this study demonstrated that resting state functional MRI image-guided radiotherapy planning is feasible and has the potential to improve cognitive outcomes in patients undergoing brain irradiation. Despite the promising dosimetry and feasibility results reported to date, several important challenges and limitations remain. Image registration uncertainty between functional imaging, anatomical MRI imaging, and planning CT can affect the accuracy of functional structure delineation. In addition, tumor-related functional reorganization may alter the spatial location of cognitive networks, complicating the interpretation and reliability of functional maps. Also, most available studies are constrained by small sample sizes, which limits statistical power and precludes definitive correlation between dose reduction and meaningful neurocognitive outcomes. Furthermore, the existing literature is predominantly composed of dosimetric, feasibility, or observational studies, with relatively few incorporating prospective cognitive assessment or long-term follow-ups. As a result, there remains insufficient high-level evidence directly linking functional imaging-guided radiotherapy planning to sustained preservation of neurocognitive function. Future work should focus on larger prospective trials to determine whether functional avoidance strategies translate into measurable long-term cognitive benefits without compromising tumor control. Robust longitudinal studies with standardized cognitive assessments are essential to clarify whether observed dosimetric advantages consistently result in clinically meaningful and durable neuroprotection over time. Standardized functional imaging protocols and integration with adaptive radiation therapy to account for anatomical and functional changes during treatment can also be considered. Similar principles of functional guided radiation therapy are increasingly being applied in other disease sites, reinforcing the broader shift from uniform organ sparing to selective protection of critical functional substructures. For example, in lung radiation therapy, advanced functional imaging techniques such as ventilation perfusion imaging and 4D CT are used to identify regions of the lung that actively participate in gas exchange. Treatment plans can then be optimized to preferentially spare these highly functional areas, reducing the risk of radiation-induced lung toxicity, such as pneumonia and fibrosis, while maintaining overall tumor coverage. In cardiac radiation therapy, the paradigm has similarly evolved from avoiding the heart as a single structure to selectively sparing radiosensitive cardiac substructures and functional zones, including the coronary arteries, cardiac valves, and the conduction system. Growing evidence indicates that these substructures are particularly vulnerable to radiation exposure and play a key role in late cardiac morbidity. Cardiac MRI imaging and dedicated cardiac atlases have facilitated more accurate identification of these substructures on treatment planning CT scans, enabling targeted dose avoidance. Notably, multiple studies have demonstrated a correlation between increased radiation dose to the left anterior descending artery and a higher incidence of adverse cardiac events, underscoring the clinical relevance of substructure-based planning. Together, these developments illustrate how functional and substructure-guided radiation therapy can reduce treatment-related toxicity and provide a compelling parallel to the application of functional imaging for cognitive preservation in glioma radiation therapy. To conclude, preservation of cognitive function is a critical component of modern glioma care, particularly as treatment advances continues to improve patient survival. Functional imaging provides a powerful tool to better understand individual brain organization and enables more personalized radiation therapy planning that extends beyond traditional anatomical constraints. Emerging evidence demonstrates that functional avoidance strategies are feasible and can meaningfully reduce radiation dose to cognitively important regions while maintaining tumor coverage. Although current data are largely dosimetric and observational, these findings highlight the significant potential of functional guided radiation therapy to improve long-term neurocognitive outcomes and quality of life. Further high-quality prospective and randomized studies are needed to establish robust clinical evidence and support the routine integration of functional imaging into glioma radiation therapy practice. This is the end of my presentation. Thank you for your kind attention, and these are my references.
Thank you, Li Wen, for your valuable sharing on the evolving role of imaging in precision radiotherapy, demonstrating how function-sparing approaches may help to support improve in patient outcome and quality of life. So now I would like to invite all our speakers back in the room so that we can start our Q&A session. I think we have quite a few questions here. So maybe Pichi, you want to come in also because there are some questions also on the certificate. Okay, so maybe we want to start with the first question on the AI. What is the future perspective of radiographer or RT with the integration of AI and automation technology? Now, Papong, you want to share anything?
Yeah, I think we need to work on that, kind of standardize our education and training because of course it's paradigm shift already because AI has been integrated both imaging and therapy. So how can we cope with this kind of technology in terms of education and training? I know that a lot of places they have implemented this already, but there are two things I think, education and training, and then another thing is like things that involve the professional practice. How can we work on this? Because at the end, AI doesn't have legal responsibility. Like once we integrate the AI into our working environment, like in imaging, like auto positioning, auto protocoling, then at the end, the license or registered technologist or radiographer needs to approve whatever the AI has made the decision. So at the end, it's more like we shift from someone who operate the machine to someone who kind of approve what the machine suggested us to do. So legal responsibility must be there. So I think at the end, we need to implement the education and training, also the CPD, continuous professional development, because like us, like you guys here, maybe we have not learned anything about MRI in our school time. Now we have to come back to learn more and work with them. That's what I think.
Yeah, thank you. Philip, do you think there's any impact on the AI in Africa or in the developing country with the implementation of AI?
Um,
Do you foresee any impact on the training or education?
may,
Is it going to
maybe,
make our work easier?
yeah, maybe, but I think the first is a totally different level of education in Africa. You have some radiographer work in the bush, and they only need some education about radiation protection and a basic radiology. And you have in some big countries like Rwanda, Tanzania, Kenya, in the hospital where you can have the help of artificial intelligence. But I think more for the radiologist than the radiographer. You see, Africa are always there's always a big delay from what we have in developing country and then in the African countries. But it's less and less now because most of the government, as soon as they have good finance, they want to put money in healthcare. So maybe I am, but for me it's a little earlier. It's too early. It's too early.
Thank you. Liu Wen, do you want to share anything on AI in radiotherapy side?
Yeah, I feel like AI is a very exciting field, even in radiation therapy. I think we are seeing a lot of auto contourings for delineation. It definitely helps in easing the workload, especially for our radiation oncologists, speed up the entire workflow so that we can churn out the plan in due time and provide more timely care for our patient. So I think that's definitely something that's really exciting, and we can actually see that implemented in centers in Singapore already. And I think looking forward, even with adaptive radiation therapy, there's also a lot of excitement in terms of how AI can help in the auto planning to come up with a robust and high quality plan in a shorter period of time. So with that, I think we can continue to look forward to a lot of upcoming advancement in AI. But like what the other speakers have also mentioned, AI also has to be used with due diligence. There has to be many quality checks to ensure that whatever that care that we deliver to the patient, it's still safe and definitely something that is of high quality as well.
Thank you. Thank you, Liu Wen, for your sharing. Okay, we have another question probably for Philip. So are there any possible workshops in the African region, particularly specifically in countries like Zambia, Angola, Namibia?
Yes, it's good idea, but the problem is you need to have a good contact with the societies to organize a workshop in Africa. I think I have no contact with Namibia. Even I want to go there one time. I've been several times in South Africa. and Zambia as well. In the past, long time ago, we have Zambian colleagues who attend our World Congress, but now nobody. So Uganda was the same. So if we have a strong society with them, it's not a problem between ISRRT, the vendors, because between ISRRT, the vendors, because most of the vendors they help us and to organize on site.
Thank you. Thank you. There are some questions on the cert. Will they be getting their certificate?
All right, so because we have so much attendees here in Zoom and some more who are also joining us via YouTube, so we make sure that we send all the certificates for qualified participants, those who have attended the Zoom meeting for minimum of 75% of the entire duration. You shall receive your certificate via email. Make sure you give us the right email address. And because we are so many here, it takes a while sometimes to send off all the certificates. So please bear with us, but we will definitely send you all your copies.
Thank you, Pichi. So I think there's another question here on the patient safety and legal liability. So I think there's issue about the profession using unqualified personnel in imaging to do X-rays. So are there existing health regulatory rules that empower qualified radiographers to challenge these practices to enforce mandatory licensing?
I have a question on check week.
Yeah. So I think it's actually more of a national issue. So previously, before we have the mandatory licensing, actually there's nothing to stop the unqualified radiographers from practicing. So I think the only way to go through is probably that we need to have support from the top down, from the government agency. So probably it's important for you to engage with your ministry, with your radiologists, with all the ministerial level to lobby for that. It's important to have qualified radiographers to operate the X-rays machine. Maybe Napapa, you got something to share on that?
Yeah, I think I agree with you, Sheikh, where you have to
Yeah.
to go through your national legislation, like the law, to enforce the licensing. But issues has been raised by some of our member societies that these might not be encouraged by the government. So ISRT stands by you. So like we sent a letter of support like last one in Spain. We sent a delegate Hakon Jamlid, our vice president, went to the EU Parliament to support our colleague, Spanish colleague, because in Spain, the government did not really support their education and training, so they are more like not at the bachelor degree level that's stipulated by the European standard, the EQF system. So the reason is like if you are not at the level, so the progress of your profession in the government system won't be at the level like that you're supposed to be. So that's something that we stand by you. And I also got request from the Indonesian colleague, President Sugianto just request us to send a letter of support because like it happens. I think even in Thailand we have like a lot of time we don't have enough qualified radiographers, and then there's a need to have someone who are not qualified to do the work, and that's something that we have to look at. Even in Thailand we have serious shortage of radiographers, more than 100 hospital having X-ray machine without registered technologists. So it's a big headache. So there are two key things like, do you want to register those assistants to have the limit scope of practice under the licensed technologist? This is what I'm trying very hard to do. I am the president of the Radiologic Technologists Board of Thailand, but resistance came from our colleague because they feel like if we let this unqualified person practice, the government may not release the position in the system for the qualified radiographer. So there are pros and cons because like if you don't control them, then what are we gonna do? The government, they have the authority to place these people on in the field anyway. So unless we put them under our license, like they have limit practice under our supervision, or we just let them do it. So it's kind of pro and con, I think. So it's up to your country the way you want to handle this. I think Philippe raised your hand.
Philippe?
Yes. I just tell you, I was in Morocco 2 weeks ago for the National Congress of our colleague in Morocco. It's the same issue in Morocco. They have a problem with unqualified radiographers who work, especially in the private sector. But it's one of the issue worldwide because we have more and more machine, even in radiotherapy, in oncology, in CT, MRI, everywhere. It's not a problem to have machine, but it's a problem for radiographers to have good radiographers who can work with this machine. So I don't know how to solve the problem. We try to solve the problem in France because the objective of the government is to have qualified people. So we open more radiographer school, and we open around 20 radiographer school in France since 4 years. And now we have not a small lack of radiographers, and now it's better. It's one of the solutions, but it's typical an objective of the government to improve the situation by opening school, by offer more salaries. But it's a long discussion. I don't think that ISRT could solve the problem, but the ISRT role for me is to say to all the government that we need to they need to find some solution.
Thank you,
Okay.
Philippe. And Mr. Locke?
Yeah. Hello. Thank you. I have a question for Napapong first. After that, the question for Philippe Jason. Napapong, continuing your answer, I have a plan to rebuild radiation safety code for Vietnam. Of course, we have collaboration with military healthcare, very good. And we have a long time ago radiation safety codes, but too old now. And then I want to rebuild again for in government. You can recommend for me how we start. Remember, now have AI, many AI includes and many new model machine. In Vietnam also have a new model machine like a CT or ISRRT machine, many new model. And then you recommend for me how we do continue for in rebuilding radiation safety code for in Vietnam.
I think there are recommendations out there from the International Atomic Energy Agency, the IAEA. There are structured courses. Basically, Vietnam is the member state of United Nations. You can request this through the IAEA. They can send expert to help you establish this kind of system. But through ISRT, of course, we have the specialists here also. We can discuss, and then we can start from there. Because at the end, you need to integrate radiation protection into your training curriculum for your undergrad students, and then professional development we add up to build your professional capacity. As like TSRT, the Thai Society used to work closely with the Myanmar Society. We went there to host the radiation protection course for the Myanmar technologists. We can also discuss, it can be like 2-day course, something like that. We can help you implement. Just let us know. Through the ISRT, talk to Chekwi and Kodama, and then we can establish this together.
Thank you, Napapong.
Philippe, you want? Oh.
The next question I will have with Philippe Jason. The first, thank you, Philippe Jason, in 1999, you support for Vietnam because the last time we not have yet society now better. Okay, I want to ask you because you have many experience for support for Africa. The first question, you can tell with everybody in Africa, they have many society, national society, and how you connect with them The first question. The second question, for example, in Congo Congress in next year on this year, or how you host for them AFPPA or ISRRT host in Congo this year Congress. How you host with them? And then the second, I saw you invite many company like United Imaging or Newsoft connect with you for support for them. Reason why? Because in Asia want to learn from you. For example, next year we support Czechia and we will support for Laos. We need your experience. Philip Jason. Thank you, Philip Jason.
Okay. The first question is about the societies in Africa. So we have most of the country have a society, but some are active and some are not active. It depends. Sometimes we are in touch with them, and then the president changed. We have no news. They change the email. It's very, very difficult. But with the main society, it's not a problem. But you have to be in touch with them not only by email, but I'm in touch with them by WhatsApp, which is the best now. For your second question about the sponsorship for the Congo. We plan to organize, as I told you, in November, but before they have presidential elections. So it's important in Africa because maybe they change the president or the military will go. So we can't start the preparation of the workshop before May. We'll have good contact there via WhatsApp, and we plan to organize maybe in a Catholic place or at a Congress Center. It depends on the money we have. ISRRT provide money, the French Association provides some money, and for the third question, and the same for Africa, we have good contact with some company like Newsoft. Newsoft will be sponsor for a workshop in Congo. Stephanix, maybe Fuji, and your question how to proceed to get sponsorship for our Congress. What is important for company, for United Imaging, for Newsoft, for Stephanix, for Gerbe, is when they speak with us, which is a goal we have at ISRRT. Our goal is that our network. If a company asks me, Philip Gerson, I want to speak with a radiographer in Burkina Faso, I want to have some contact in Burkina Faso, I can give him the name of the people immediately. And it's the same for Napapong in Myanmar or you in Laos. And the company are very interested by our network. It's our goal. That's what I want to tell you. And don't give them all the name. Take the control on that, because otherwise they skip you.
Thank you, Philip. Thank you. Thank you,
Thank you, Philip. So maybe we have a question from Mr. Mohan.
Yeah. Now it's another question. I just would like to add that external agency cannot dictate their term to any government, whether it is elected government or the army government. Only we can encourage the qualified people of that respective country to be united and demand from their government to form either a board or a council or a commission or a society. And ISRRT can help them or teach them how to be united and how to demand from their government, because it's a policy decision, that is the political willingness is needed to form a council or board or commission to organize or to bring a profession under the rule or regulations. So I think our role is limited. Only we can help them to start their willingness to come under a regulatory mechanism where the regulatory mechanism should control that no unqualified personnel should work. Moreover, we can request to the manufacturers when they are supplying their equipment in that country, they should not give AMC, means annual maintenance contract, if the equipment is operated by the non-qualified personnel.
Thank you, Mr. Mohan, for your sharing. Okay, thank you everyone once again for being here tonight and spending your Friday evening with us. I think we have now come to the end of this webinar session, and the presentation that I've heard today really embody the spirit of ISRRT in promoting education, fostering global collaboration, and strengthening our profession through sharing of our knowledge and experience. So with that, I would like to end the session today, and I would like to wish everyone a pleasant evening and an enjoyable weekend ahead. Thank you everyone for coming in.
Yes,
Pichi,
thank you.
you have anything
Yes,
to add on?
thank you, Madam Chekri, for your wonderful moderation of the session. Thank you very much to our presidents and our panelists, and of course to the ISRRT board management and officers. Thank you, President of ISRRT, Dr. Napapong Napang from Thailand, Vice President Madam Tan Chekri from Singapore, Sir Philip Gerson, our treasurer, and our selected speaker from Singapore, Ms. Ye Wee Lin. We have learned so much from your very interesting discussions, and we are excited to see you again soon. But I'm sure that many are also excited to hear about the next month's CPD Asia and to give us an invitation and tell us more about this exciting event. And let us welcome the MRTA Chairman, Jerry Pedro Lay.
Hello, everyone. Yes. It's our honor and our pleasure to announce that the MRTA will be hosting the next online CPD webinar in March. We will release and publish the online registration poster once the exact date is finalized. Very likely, it will be in the last week of March. We warmly welcome all colleagues and friends to join us. We look forward to seeing you all soon in March.
Thank you, Chairman Lay. We will definitely save the date. So finally, we would like again to express our sincere gratitude to the ISRRT for your unwavering dedication to advancing our profession, for your continued support to the CPD Asia program, and for graciously hosting the 59th CPD Asia and helping us also host annually a CPD Asia session. Your leadership, Dr. Napapong Napang, our VP, Madam Tan Chekri, and Sir Philip Gerson, Sir Naoki Kodama, and all your commitment to global radiography education are deeply appreciated. We also would like to extend our heartfelt thanks to VT Healthcare Vietnam, to all our Zoom sponsors for their generous support. We also deeply appreciate the ongoing cooperation of CPD Asia IT team and the unwavering support of all our presidents and officers who work tirelessly to bring you meaningful CPD Asia sessions every month. Above all, we offer our warmest thanks to all our registered participants. Tonight, we have 555 who are here in Zoom and some more live audience in YouTube. Your presence and enthusiasm have truly made this online CPD Asia program a success. We shall definitely deliver your certificate. So again, I warmly invite you to join us again for the next CPD Asia session next month. Once again, I'm Pichi Luna, your host, saying thank you, everyone, and we'll see you next month. Hope to see you in Dubai, October 2026.
Thank you.
Thank you, Dr. Napapong, Madam Chekri, Sir Philip Gerson, Ma'am Wen.
Thank you.
President
Bye-bye. Thank you.
Thank you. Bye.
Chairman Coranang, VP
Thank you all.
Hey, hi.
Hope to
Lakwan,
see you in
Madam
Dubai.
Chan.
Yeah, happy New And
Mr. Mohan, bye.
Bye.
bye-bye.
Happy New Year.
Happy Days.
Happy New Year.
Happy New Year, Denise.
See you soon.
Happy New Year to all. Thank you.
Thank you, Madam Chekwi. Good night in Singapore.
Thank you, Peachy. Thank you so much.
Recording stopped.